So hopefully you can see me and hear me well. Thank you very much for inviting me to give a talk today. I really hoped I was in person with you in Bilbao, but in any case, I really hope to have a lot of interaction with you at the end of my talk. I'm going to talk about today on how I believe that machine learning can drive a transformation in healthcare delivery. And I always like to start with this quote from William Osler, the father of modern medicine. If it were not for the great variability between individuals, medicine might as well be a science, not an art. And indeed, medicine is very hard, and this is due to variabilities between individual patients, their different genetic background, environmental exposures, lifestyles, histories, and treatments over time. And this leads to different risks, variation in symptoms, health and disease trajectories, as well as responses to treatment. And the art of medicine has been to make judgments on the basis of such complex information to manage patients. And what my group and I are aiming to do is to build machine learning technology to empower clinicians to turn this art into a science. So we believe that machine learning can transform healthcare by delivering precision medicine at the patient level, understanding the basis and trajectories of health and disease, empowering healthcare professionals and patients, informing and improving clinical pathways, better utilization of resources, and reducing costs, transforming population health and public health policy, and enabling new discoveries. Let me say up front that I do not believe that machine learning can ever do medicine. What I believe it can do is provide interpretable and trustworthy actionable information to clinicians in the form of personalized risk scores, treatment recommendations for the patients in front of them, data-driven hypotheses, and a variety of other trustworthy recommendations. As a matter of fact, my lab has provided a set of engagement sessions with clinicians that we call Revolutionizing Healthcare. We started this engagement session with clinicians around 1.5 years ago. And if you are a clinician in the audience, I would like to ask you if you are interested to join us, and the link for joining us is shown below. And if you are interested in these sessions, but you are not a clinician, you can find all the sessions online on our YouTube channel. The reason we started these engagement sessions is because we want to discuss with clinicians to understand which problems they would like to be solved using machine learning, rather than ourselves invent problems that may not be there at all and clinicians may not care about. We are discussing in these different sessions with clinicians various different types of tools, machine learning tools, personalized therapeutics, machine learning tools for cancer, for acute care, for transplantation, as well as machine learning interpretability. Please take a look. In a separate set of engagement sessions aimed at machine learning students, but also any machine learning enthusiast, we have discussions about machine learning models and what they can do in medicine. This session is called Inspiration Exchange, and you can subscribe to it if you are interested to understand more and learn more about machine learning models in medicine, as well as engage with my group and discuss how we can join forces to build machine learning that are useful for clinicians and patients alike. Today, I'm going to have a two-part talk. First, I'm going to stay relatively high level and discuss the healthcare ecosystem and how can be empowered by machine learning. And then I'm going to take a very concrete example, early diagnosis and detection of disease. And this is especially a hard area in medicine. And I'm going to provide some thoughts about how I believe that machine learning can help bring this healthcare's holy grail within reach. So first, what can machine learning do to transform healthcare delivery? It can provide recommendations in order to get the right care to the right patients at the right time. And the focus will be to achieve the best outcome for the patients at the lowest possible cost. And this is possible by providing personalization, but not only personalization for patients, also personalization and decision support tools that are personalized to the clinician, the specific specialty and patients they are seeing, as well as the healthcare entities where the care is provided. So personalization going beyond just the patient to the entire healthcare ecosystem. Also, machine learning can enable lessons learned in one particular hospital to understand whether they would apply and be useful to another hospital or another clinic. And as this pandemic has shown, it's important to learn at scale and learn from each other what are the best practices for different types of patients. Another important aspect where machine learning can help is identifying better ways of working and inefficiencies. How can one build teams of clinicians to take care of a particular patient given their unique characteristic? I'm going to give some examples of that a little later. But also provide concrete policies for improvement. And here I'm not only talking about providing healthcare for a particular patient, but also about how to schedule better resources, when a patient should come back upon a particular disease being diagnosed, as well as what is really the best scheduling strategy for a particular specialized clinician or a particular healthcare resource that is very scarce. In order to really divide the different classes and types of machine learning methods, we have developed this framework that's highlighted here in this table, where we divide the machine learning methods in 4 different categories: patient-oriented and narrow, in the sense that the focus is only on a particular patient rather than an entire population. And for that, we are going beyond precision medicine into what we call bespoke medicine. If you want to learn more about bespoke medicine, we have an entire session dedicated to it on Revolutionizing Healthcare engagement session, and you can take a look. Then we have profession-oriented, and in this case, the focus is on building tools that are empowering clinicians. Then, at a more broad level, we have population health and public health policy tools, and profession-oriented, but at a larger scale, system pathways and processes that can empower an entire clinic, hospital, or an entire country. And the reason this division is useful is because certain tools are very useful for a particular stakeholder and for a particular entity or for an entire ecosystem. Let me, before I say more about what machine learning can do, say why I believe that this is the right time to provide such a transformation of the healthcare ecosystem using machine learning. On one hand, as you are going to see a little bit later, machine learning are becoming of age and are ready to be used. Also, in order for machine learning to be useful, it needs to be applied on diverse sources of valuable information. And we have an unprecedented access to such sources of information, whether it's clinical notes, electronic health records, clinical registries, prescription information, but also appointment information as well as wearables. And COVID-19 has been terrible for all of us, but it has accelerated access to digital information and digital information collection. So we have new sources of information that we can use to to apply machine learning to in order to empower clinicians and patients and healthcare systems. What type of empowerment I'm talking about? Personalization and decision support in the form of personalized screening, personalized monitoring of patients, enabling, as I'm going to talk a little bit later, early diagnosis, upon diagnosis, personalized treatment plans or recommendations. And what we have been trying to do in order to express what is possible is build a variety of demonstrators that were co-developed together with various clinicians, whether it's for hospital care, whether it's for the treatment of breast cancer or organ transplantation. And you see here a few examples of the demonstrators that we have built together with clinicians to highlight how these different machine learning tools can be used in practice to empower the clinicians and the patients they are seeing. More generally, machine learning really can go beyond just personalized and precision medicine. It can enable clinical research in the form of discovery, whether it's drug discovery or physiological discovery. It can enable patients through recommendations that are personalized for them, clinicians through tools, hospital managers by providing analytics and operational support, as well as healthcare bodies by developing clinical practice guidelines that are data-driven, and last but not least, public health policies and public health analysis, as was very important in this pandemic. And if you want to see what we have done during this pandemic, mainly in the UK, but also with a variety of collaborators outside the UK, you can see our website under the impact section, and you can see the work we have done on COVID-19, just to highlight what is possible if we join forces together. Most of the work that I do is really aiming at develop machine learning methods that can empower clinicians, because in my opinion, they are really the central point in providing healthcare delivery. And if we can empower clinicians with tools that they can use to better take care of their patients, we already made great progress. So machine learning for clinicians, what do I have in mind? Machine learning can empower general practitioners, primary care clinicians with tools for symptom tracking, symptom assessment, early diagnosis, as I'm going to talk about later, and a variety of other recommender systems. And they are very busy and see very diverse set of symptoms and patients. So this is actually very hard. And any tool that can triage the patients or that can enable them to better take care of their patients is powerful and important. For secondary and tertiary care, bespoke medicine can really be created to meet specialized needs. For instance, when should a patient be treated for a particular disease and how they should be followed up after the treatment? Or during hospitalization, when should a patient be admitted to the ICU and when should a patient be discharged? Also, patients that are vulnerable, whether it's elderly or patients with multiple comorbidities, are especially complicated. And this is a setting where diseases are evolving over time and co-evolving over time given the comorbidities. So this is a hard longitudinal problem where a diverse set of data needs to be aggregated. And predictions need to be made over time to issue warnings about different events of interest for these vulnerable, complex patients. These are also the most costly patients and most complex patients. So machine learning can be used to really empower healthcare ecosystems and clinicians to better support such patients. What type of machine learning methods? Methods that can build and understand comorbidity networks, how one particular morbidity is affecting another morbidity over time. Temporal phenotyping, which aims at understanding and forecasting how patients evolve over time and what type of events of interest we are expected to see and when, such that these patients are better monitored and screened over time. And personalized therapeutics. Many of these patients may take multiple medicine and multiple medications over time that may interfere with each other and may lead to competing risks. How in such a complex setting we can decide what treatments to give and their interactions over time for this specific patient given their unique characteristics. Also, machine learning can be used to empower patients. And here really the big challenge, but also the big promise, is to integrate diverse sources of information, whether it is clinician notes, images, tabular data, as well as real-world data and sensor data, in order to issue warnings, advice, and recommendation to patients to better take care of themselves, and also to know when they need to go and visit their clinician and how to better really take care of their health. Finally, this entire, let's say, transformation will only happen if machine learning also can empower the healthcare ecosystem at scale. Clinicians, clinical leaders, hospital managers, and a variety of clinics. And here machine learning is really not highbrow machine learning, but more machine learning aimed at providing efficiency to deal with the tedious tasks of resource allocation, scheduling of patients, scheduling of resources, whether it is imaging resources or surgery or hospital beds. And during this pandemic, in a variety of countries, even the wealthier countries, had a big challenge to efficiently use the scarce available clinical resources. And this is where machine learning can help a lot by enabling forecasting over time, and better planning of resources on the basis of the forecasts. This also enables efficient triaging to understand which patients can wait and for how long, and which patients need to be seen immediately. Also, when we are forecasting the benefits and the advantages of a particular resource utilization, we also need to understand what is the impact on the patients in the short run and in the long run, and look at a variety of metrics and the quality of well-being of these patients over time. Really, in order to enable things like that, we need to learn and collaborate across integrated systems. For instance, we may want to learn about what is the best treatment for a particular class of diseases, for instance, heart failure, or a particular type of cancer, or COVID-19, in one country, and try to see if any of the lessons learned in that country can be transferred to another country, such that countries can learn at scale from each other, despite the differences between their patients and differences in healthcare ecosystems. And this is an enormous opportunity, but it is also hard. However, if we can do this well using machine learning, we can minimize inappropriate variation in clinical practice. And what I mean here is, of course, there will always be desired variation in practice because patients are different and they need to be treated differently, given their unique characteristics. But what we are wanting to do here is to minimize inappropriate variation in practice, where even for the same patient, different clinicians or different healthcare systems would treat these patients differently. For instance, in United Kingdom, cancer is often diagnosed late, and this puts a significant impact on patients that have cancer. Their survival rates are lower than other countries that can diagnose patients early. So we would like to understand, why is this variation in practice? Why are the patients diagnosed late? And what can we do to reduce such diagnosis times? And this is just one of the many examples where machine learning can look and analyze why there is variation in practice that's undesirable, and can we turn this into clinical practice guidelines or decision support systems for patients and healthcare systems to reduce such inappropriate variation. And here we have machine learning methods that can transfer between different countries or different healthcare systems, that can enable the efficacy of a particular policy or clinical practice guideline. It can enable better resource forecasting, but also new types of machine learning. I'm going to very briefly talk a little bit later in this talk about a new type of machine learning that we call quantitative epistemology that was pioneered by our lab. And the focus there is to understand decision-making made by clinicians by observing the data that they take into consideration and their decision-making and what type of decisions they make over time, with an overall goal to distill insights that can then be shared to improve best practices across healthcare systems. In order to anchor these ideas, I'm going to give a very concrete example from early detection and diagnosis of disease. Associated with this, we have in our Revolutionizing Healthcare engagement session, two sessions. One was already in February 8th, you can take a look at that, and one will take place on March the 10th that is dedicated to this. So early diagnosis and detection is complex, and just to highlight the complexity of it, I took here two examples of two different schematics that appear in childhood cancers and adult cancers in BMJ. And what you can see is how difficult it is, how difficult the symptoms are, and how complex the referral pathway is. And this is why at times cancer is diagnosed late. Cancer is just one example. It's a good exemplar, so at times I'm going to give examples of cancer when I'm going to talk about early diagnosis and detection, but this is more generally the case, and much of the discussion here will apply to early diagnosis and detection of other diseases in addition to cancer. Current thinking in early diagnosis and detection in medicine usually uses risk predictions, which are segmenting individual patients using population-based rather than individualized risks. And these are usually based on few variables. They are rarely based on longitudinal time series data about the patient, and usually are calculated only once. For instance, in the United Kingdom, often the Q-risk is used to issue predictions for cardiovascular disease or cancer. And it is such a population-based risk based on few variables, not longitudinal, and usually calculated only once at a particular age of the patient. And risk scores are then leading to guideline-driven management of patients, and this is often rigid, one size fits all. And what's even worse is that many diseases lack guidelines and protocols altogether. So in order to really do better in terms of early diagnosis and detection, we need a much more quantitative and holistic understanding of disease progression. And to understand why we are only so far in enabling early diagnosis and detection, we need to understand that this problem of understanding disease evolution and disease trajectories is hard. For instance, you see here a variety of clinical observations starting from background risks that may be based, for instance, on genetic information or family history, which at times may not even be computed for a particular patient. Then we may have early signs and indicators of disease that may be vague and confusing. Then maybe non-specific symptoms, and if we wait long enough, specific symptoms may develop, but by the time it's often too late to treat certain types of diseases effectively. And this is what we observe over time for a particular patient. And the underlying unobserved progression of disease leads really to these types of observations over time. So as the patient is moving from a healthy underlying state to a disease state, these different types of observations are appearing. But the underlying hidden state of the patient is unknown. Since it is hard at times for different types of patients and for different types of diseases to understand how many stages and states of disease does a patient pass through. And is this modulated by genetic information, by environmental factors? And is the patient going to stay in a particular state for a certain amount of time until they are going to move to a new state or stage? And note that I'm talking about stage and states of disease here very generally, and this really is a quantitative concept of disease evolution that can be applied to any disease, not only cancer. And if we are able to do that quantitatively, then we can have windows for acting. For instance, windows for early detection of early signs and indicators, when we can diagnose, for instance, a particular disease early before really pathology sets in. So the question is whether machine learning can help with this complex underlying evolution of disease. I'm going to go through a variety of topics today, but if you want to read at length about these different topics and the machine learning underlying this, please take a look at the website that we have created under early detection and diagnosis on our website. I'm going to start with risk prediction. As I mentioned before, risk prediction is already done in a certain number of diseases, but it has disadvantages, as I mentioned before. So the question is, what can machine learning add on top of current risk prediction methods? First, we can move beyond population-based risk to personalized risk. Competing risks. We do not only want to look at the risk of a patient for developing, for instance, breast cancer, and separately ovarian cancer or cardiovascular disease. We want to look at competing risks simultaneously. Also, machine learning can integrate easily diverse sources of information, family history, social-demographic factor, genetic factors, and environmental factors to issue personalized competing risks. It can also integrate complex multimodal sources of information. So many of the current risk predictions that are used in medicine are based mainly on tabular data and at other times mainly on imaging data. What we would like to do and what is possible using machine learning is to integrate complex multimodal information to issue such personalized predictions of risk. Also, machine learning has been shown in numerous cases to provide improved accuracy for patients, and it comes with uncertainty quantification as well as interpretability. I will not have time today to talk much about interpretability, but the reality is that machine learning is nowadays very often interpretable, and we have methods that enable us to provide interpretations associated with them. So, another thing that is important and machine learning can provide is personalized value of information. So what type of information we would like to measure for a particular class of patients in order to issue this prediction of risk for a particular disease. So it is not the more information the better, but what is the valuable information should be acquired for this particular patient, what type of tests, for instance, should be done for this particular patient given their background risk in order to issue the most accurate prediction necessary. Also, at times, new sources of information are appearing over time. For instance, there is discussion of new tests in the form of liquid biopsies or other types of tests, as well as wearables and other types of sensors. Such new sources of information can be easily incorporated to issue predictions of risk using machine learning. Also, the patients are continuously changing. They may develop with a higher or lower risk different types of morbidities. For instance, on the basis of the environmental factors, or for instance, their diets that are changing as populations are changing over time. And in order to enable of this, all of this, we would like to do easy and automatic training of machine learning models. And for that, we would like to use automated machine learning. This is especially necessary if we want to produce risk scores for a variety of diseases. So the focus of automated machine learning is not to automate the clinician, but to automate the machine learners like me, such that somebody can provide a data set for a particular disease, and then at the push of a button, AutoML will select the best machine learning models, whether predictive or causal, for that particular data set for the risk of interest. And machine learning automation is important because we have different types of machine learning models, and the machine learning community is very creative, so non-stop new types of machine learning models are developed, and their performance can drastically vary for a particular data set and a particular prediction. So for instance, for cardiovascular disease, as opposed to, for instance, organ transplantation. And we need at times to update these models regularly as we collect more data, different type of data, as well as the data may be changing. So it's extremely important to have automation of machine learning methods such that the best machine learning model is selected. And this is especially important since machine learning pipelines for risk predictions are complicated. We need to select not only the machine learning model, but also the parameters of the different machine learning models. We also need to deal with missing data, so we need to do imputation. We may have a variety of features, so we need to do feature processing. So we not only focus on classification and risk prediction, but also on imputation, feature processing, and also calibration, such that the predictions are calibrated to the population of interest. So automated machine learning can enable us to take a data set and then select the best models associated with this data set given the predictions that we would like to make. We also want to issue not only predictions but also interpretations and trustworthy estimates associated, trustworthiness, meaning uncertainty estimates associated with the various predictions. An example of some of the automated machine learning methods that we have built in our lab are the adjutorium framework and the autoprognosis methods. What is autoprognosis? This is a tool that we have developed in our lab a few years back that is able to craft such clinical scores at scale. We feed in a clinical data set and a prediction of interest, and then at the push of a button, we can issue predictions, explanations, and in the more recent adjutorium framework, an entire user interface associated with it, such that the clinicians can very easily adopt it in, if they want to build a risk score themselves. Also, we are able to learn from complementary cohorts, either in another hospital or even in another country, through meta-learning. Initially, we have applied this to cardiovascular, cystic fibrosis, and prostate cancer, but more recently, we have used this for predictions in COVID-19, as well as breast cancer. We not only want to issue predictions, but at times we want to do time-to-event analysis. We want to see how the probabilities of a particular risk are evolving over time. And for that, we need survival models. And we have developed tools for automated machine learning for survival models, competing risks, as well as causal models. If you want to read more about the automated machine learning agenda, please see our research pillar dedicated to it, where we describe some of these technologies and how they can be used in practice. Let me now go one step further, beyond just risk prediction, to dynamic risk prediction, where we are using longitudinal time series data to dynamically forecast risks for various events of interest over time. So what you see here is different types of observations that we have acquired over time at different time horizons. And what we would like on the basis of this information is to forecast trajectories of health and disease. So for instance, we want to ask questions such as, will event Y, a particular diagnosis, or a particular event such as a heart attack happen a certain time horizon in the future? And for that, we are going to use no longer just cross-sectional data like in the previous part of the talk, but rather longitudinal data. And we can, in this way, integrate complex multimodal and diverse data over time. This could be, again, imaging data, it can be clinical data, as well as a variety of other information that is aggregated over time in order to issue predictions of risk over time. This can be updated regularly every time new values become available. So unlike current predictions of risk, which are often done only once in the lifetime of a patient or at very predetermined times, here every time we have a new symptom or we have a new test, we can update these predictions of risk in the future. Also, we can include previously unused data set, easily refining algorithms. So we are moving beyond just static prediction to dynamic forecast. And for dynamic forecasting, we have built together with one of our clinical collaborators, Ari Ercole, an automated machine learning framework that we call Clairvoyance. And this uses longitudinal data for issuing predictions, whether it is in primary care, secondary care, or hospital. Now, if we can do that, we can also go one step further and do personalized screening and monitoring. And this is important because we would like to know when a patient should come back to be screened or monitored, given their risk or symptoms. And for that, we would like to answer questions such as, what is the value of acquiring a new information, doing a particular test or a particular visit over time for a particular event of interest, the diagnosis of a particular cancer, for instance, for this specific individual, given their family history. So we are able, using machine learning, to predict who to screen, when to screen, and what to screen. And here you see a few technologies that we have developed over time: deep sensing, disease atlas, and clairvoyance, that are able to do such personalized screening and monitoring over time. In this way, for a particular event of interest, for instance, the early diagnosis of a particular cancer, we can determine when this patient should come next, given the past observations about this patient. In this way, we can move from a one-size-fits-all, all women with a particular risk should be having a mammogram at age 50, to a much more nuanced monitoring and screening, where, depending on the family history and past symptoms, the patient may come earlier or later and at different intervals, and different types of imaging technologies may be applied to them. For instance, we have done just that in a paper a few years back, where we show dynamic personalized screening and monitoring, where, for instance, two patients, even though they have the same background risk, because they have different histories, they have different types of symptoms and different types of findings, will have different screenings over time. So despite their similar background risk, the screening is done at different horizons and at different times and with different modalities because of their histories. Conversely, the last two patients have the same histories, but they may have different types of genetic background, for instance, and hence different screening will be recommended to them. Not only when a patient should be screened, but also with what modality to screen can be determined using machine learning. So quite a few years back, together with a few radiologists at University of California, Los Angeles, we looked at patients which are at high risk of breast cancer and tried to determine what's the best screening modality to use for them. Shall we do only mammograms? Shall we do mammograms and ultrasounds? Or shall we do MRIs? And given the different costs as well as benefits for different classes of patients, we identify the optimal modality to use for screening for the patient at hand. Now, let us start to look at how can we diagnose disease early. Early diagnosis is more than just event prediction and forecasting. It involves really unraveling and dissecting underlying states of disease over time towards the event of interest. For instance, the emergence of pathology for a cancer or a heart attack in the case of cardiovascular disease. Again, I'm talking here about a very quantitative way in which we can think about disease progression, where we are asking how many stages of disease we have, how many states does a patient passes through, how long will they stay in a particular state, and what are observations associated with the different states of disease. So the notion of state is fundamental to understanding disease progression and doing early diagnosis. And we need a quantitative understanding of such disease progression in terms of states and state transitions over time. Current state-of-the-art disease progression models, as published in medical journals, at times use Markov models, where we have diseases progressing in different stages. And we have, the reason they are called Markov models is because the probability of transiting to a new stage only depends on the current stage of disease, not the history of previous stages. But even such Markov models are not enough. They make assumptions that are not realistic in practice. First, that the disease stages are observed. But as we discussed earlier, we have observations in terms of symptoms or different types of biomarkers, but we do not know the exact stage the patient is in. Also, they are modeling one disease at a time, and often diseases interact with each other, and different morbidities and comorbidities may influence each other. So we need to model diseases together. Also, this is one size fits all for all patients, and we know that different patients may evolve faster across the different stages of disease, may stay longer in different stages of disease, or may even skip a particular stage. So we need to move beyond this simple characterization to a more nuanced one. A first step is to introduce hidden Markov models, where in addition to the observations that are made about the patient, and when I say observations, I mean genetic information, demographic information, symptoms, lab measurements, measurements that are done, for instance, through imaging. These are all observations about the patient over time. But the underlying state of the patient or disease stage of the patient is hidden. We do not observe that. We only observe the observations. So given that the patient is, for instance, in state 2 of disease, for instance, state 2 of cardiovascular disease, we observe a particular observation, for instance, blood pressure or a particular atrial fibrillation. And this tells us about the probability that the patient is indeed in this underlying disease state 2. But this is still not enough because it still requires a Markovian model, which only depends on the current state of disease. And the reality is that history matters. And we need to care about previous states, the order of states, and the duration in a particular state. And this is one size fits all. So can we have deep learning models that can do better than that? Well, deep learning methods have no latent structure very often. And often, if we want to do it in an interpretable way, this often doesn't have these hidden stages of disease. So what we have done a few years back is we built a machine learning model that we call an attentive state-space model, which is a general and versatile deprobabilistic model, which combines the power of these hidden Markov models with deep learning models, such that we have on one hand the interpretability of hidden Markov models that have stage and disease progression, but that enable us to take the entire history of the patient into consideration. So then, as shown in here, we no longer only depend on the previous state, but the entire patient context, as shaped by clinical events, genetic information, or treatments over time. Then early diagnosis can be done in the following way. We have, for instance, a particular observation at onset. This may be family history or a genetic offset. And then as the patient has non-specific symptoms, we can start to say that the patient is now moving to the third stage of disease. And on the basis of this, we can make predictions into the future. If we do not have machine learning, we run the risk of diagnosing disease late. For instance, in this case, the patient is diagnosed only when it progressed to a particular stage of disease. That's quite advanced. On the other hand, if we have machine learning, we can use this type of information from other patients, and for the patient at hand, we can predict already when the patient was in stage 3 that it may develop the disease at a particular stage 5, and hence the disease can be diagnosed early using such machine learning support. In view of time, I'm going to now skip through a few slides, and I'm going to just say that I hope that this gives you a little bit of an overview of what can be done using machine learning for early diagnosis. If you want to get involved with us beyond this particular session today, and if you are a clinician, I invite you to join us on March 10 when we are going to go in more detail and we are going to discuss with clinicians about these different methods and what other methods we can build. Finally, if you want to see various resources, I invite you to take a look at our website, which describes some of this research agenda. And also we have in Cambridge, the Cambridge Center for AI Medicine, which brings together clinicians, machine learning researchers, and bioinformaticians, joining forces together to build tools to really diagnose disease early and empower clinicians and patients. Thank you very much.
Thank you very much, Mihaela. Thank you for your presentation. It was wonderful. Can you hear us now?
Yes, I can. Thank you very much.
So now we're going to proceed with questions. Who has questions? Microphone. Wait.
Hi, Mihaela. I'm Íñigo Gabilondo. I'm a neurologist here in Spain, and I also do clinical research. And I work with patients with neurodegenerative diseases. Thank you for your talk. It's been really wonderful, very interesting and very comprehensive. So I have a question regarding, as I said, I work with patients with neurodegenerative diseases. Most of them, they don't have a cure right now. And most of the treatments just slow down a little bit the progression. So in terms of early diagnosis and the tools that you are working on, I guess that you have many times some ethical and also in terms of resource allocation from public resources. There are some problems on that because these patients may, for example, Alzheimer's disease patients or Parkinson's disease or ALS patients, if we have an early diagnosis before symptoms occur, and we don't have an effective treatment to slow down or to stop the disease, and not only that, if the treatments available are extremely expensive or the tests that we have to use are very expensive, how do you deal with that kind of problems? Because it's complex.
Thank you very much for your question. I have heard most of it, but I'm not sure if all of it. But I want to thank you for this because it allows me to talk about a part of the talk that I didn't have time to go on to. So I'm going to just very briefly go to that part of the talk to highlight what's possible. So I didn't talk about treatments, but whether we want to really treat patients that may be at high risk before a diagnosis, or whether it's to treat patients after a diagnosis. We would like to understand what's the value of treating a patient, when to treat and how to treat. So machine learning for this is more complicated because it's not only just prediction, it's causal inference. So we need to answer questions such as what if? What would happen to the patient if I treat in this way at this moment in time? Or what happened if I would not treat? So we move beyond predictions to causal inference, where we need to estimate counterfactual trajectories. So the type of questions we can answer is how to treat, when to stop treating by looking at different types of counterfactuals. For instance, what happens if we do nothing? What happens if we do the preventive treatment? When and for how long? And this depends on the characteristics of the patient. And hence, we would like to learn from observational data of other patients, past patients, given their unique characteristics over time, patient features over time, treatments that may be given or not, as well as the static information of the patients. And on the basis of this history, we want to determine what would be the effect of different types of treatments or doing nothing. So, and this all we would like to learn from biased electronic health record data. Often we cannot learn such complex longitudinal things from clinical trials. They are too short and often they have unrepresentative patients. So we are obliged to learn from electronic health record data, which is biased. So this is hard because of time-dependent confounders, which are often affecting past treatments and influence future treatments. And for that, we developed some machine learning methods. Here is just one of them, but you can see some others on our website, and other researchers have made other methods where we are able to really learn from the past history and make predictions of different types of counterfactual trajectories given different types of treatment. And the methods used resemble ideas from machine translation, where we translate from one language to another. But this time it's more complicated because we need to translate from the history of a patient into a future of a patient, given different types of languages. And in this case, the languages are the treatments. I hope that this provides a little bit of a feel about what is possible with respect to treatments.
Thank you very much. More questions?
Hi, good afternoon. I'm Vanessa Gomez. I'm coming from University Carlos III de Madrid. I have been working with machine learning model for a long, and I completely agree with you that the model that you are proposing with hidden Markov model, with deep learnings, is quite interesting. In fact, it's what you say. You are borrowing ideas from the translation methods, and it's working. This kind of architecture, sequence to sequence, are working quite well in many applications. But I think that the main problem here in the field of the health applications is that this kind of architecture, you need a lot of data. I imagine that the number of parameters that you need to learn is a lot. In typical applications of machine learning for test translations and any kind of sequence, maybe the number of parameters are thousands, even more. So how many data are you working with to be able to deal with this machine, to training these models, in which problems really you do really have so many data, or are you using pre-training models, or?
Thank you. Yeah, no, I think I hear some of it. I apologize. I don't hear all of it, but so as far as I heard is, what about the data, and do we need a lot of data? You are right that past machine learning methods, so if you think about up to a few years back, we needed a lot of data, as you rightly say, and these machine learning methods are dumb and they need data to learn from. However, in recent years, there have been quite a lot of advances that enable us to learn from less data. Let me give you just two ideas, but there are more. One of them is we can use the knowledge of clinicians or knowledge from pharmacological models to inject in these machine learning models, such that we don't only rely on data. So together with a group of clinicians at the University of Amsterdam, we have recently published a paper in NeurIPS 2021, which is one of our machine learning conferences, but it shows a proof of concept where we show that if we have pharmacological models that we embed and use, as well as clinical knowledge together with data, we can learn from relatively few observations a lot better models than machine learning models that just with data alone. So one big promise is to use clinical knowledge, pharmacological knowledge, in addition to data such that we learn from fewer observations. So that's one. Number two, at times we can have limited data at one hospital or at one clinic, but we may have other data in other hospitals and other clinics. So then what we can learn is across different small data sets, which true, they may be different because the patients may be different and the healthcare systems may be different, but still we are able to do judicious transfer learning and meta-learning such that we can learn across these different healthcare systems and limited data and pull them together to create a bigger data set from which we can learn at scale. So we can put multiple small data sets together to create a data set that is used for learning machine learning models and then recalibrate these models for a specific hospital or clinic given their patients there. These are just two of the multiple ideas that are emerging, but I completely agree. Dealing with data, limited data, noisy data is the important frontier we need to cover as a machine learning community.
Okay. I think we're now out of time, so thank you very much, Professor Mihaela.
Thank you very much. Please reach out and join us in Revolutionizing Healthcare through our mission. And if not, just drop me an email. Thank you so much.
Thank you very much. Bye.